You can get that started.
Okay, I'll start the webinar now. Welcome, everyone. Thank you all for being here. I see folks coming into the room, um, and welcome. We've been so delighted about the response that we had for this session and glad that you all could be with us tonight. Great. Okay. Okay. We're just giving some time for a few more people to get into the room. Um, okay, great. All right, so I'm gonna go ahead and start. Welcome everyone. My name is Rebecca Shasani Ellis, and I am your moderator for tonight. And I'm so glad that you all could join us. This is the fifth annual Racism Pre-Conference session, and we are so delighted as the Public Health Nursing section to be hosting this and having some amazing sponsors and supporters of this event this year. It has meant so much to us, especially as you all know, we've had some pretty interesting historical events this year, but I would call it a burden to really talk about racism and how we can dismantle systems such as this that affect so many of our population, and a system that disproportionately affects Black and Brown people. So, and we will be talking about, and the title of our session this year is Birthing While Black, the impact of obstetric violence and responses to systemic racism in maternal health. We have an amazing group of panelists with us today. So for those who are saying your thank yous and hellos, thank you and hello. And I would like to, since I won't be able to say a lot of thank yous later, I want to give a big thank you to all of our sponsors for this event, as well as the amazing work that the Racism Pre-Conference Session Subcommittee has done this year to, despite COVID-19 and the racial violence, anti-Black racism and violence erupted in our country this year. They have worked diligently so that this program could get to you tonight. So thank you all for attending. And our sponsors have made sure that this could be free. So we are glad that you're joining us. Thank you, Michelle. Okay, so I'm going to do introductions of our panelists, and we have some amazing folks here with us tonight. Um, our our first panelist is Rachel Adelenko Akwete, and she is a senior public health nurse at Fairfax County Health Department in Virginia. She obtained her bachelor's of science in nursing and her master of public health degree from the University of Wisconsin-Madison. And her current role, she serves as a liaison for the health department with federally qualified health centers. And she works to improve health outcomes and maximize individuals' health potential. As a public health nurse, Rachel has been passionate both at the national and global policy level. Her policy advocacy work has included notable achievements such as having her former congressperson co-sign the Global Partnership for Education resolution, and this was done for the first time in 2017. And more recently, advocating successfully to eliminate birth cost recovery policy, a policy that contributed to Black infant mortality in Dane County, Wisconsin. Rachel has also published multiple pieces for media, including an op-ed on her work with the Global Partnership for Education Secretariat. Our second panelist is Miyoshi Benson. Miyoshi is a senior advocate at the Women and Justice Project, which works to advance the leadership and build power of currently and formerly incarcerated women. Miyoshi spearheads WJP's public engagement work and helps lead partnership work with women directly impacted by incarceration. She serves as the main spokesperson for WJP in the public press and has been featured in a variety of publication forums, such as the Huffington Post, The Nation, and Al Jazeera America. Miyoshi is a leader in successful campaign that passed in New York in 2015, an anti-shackling law, which strengthened and expanded the ban on barbaric practice of shackling incarcerated pregnant women as they progress through their delivery. Miyoshi is a recipient of the 2015 Susan B. Anthony Award from the National Organization of Women, New York City, and the 2016 Our Children Mother of the Year Award. Miyoshi resides in Long Island City with her two children and is pursuing her bachelor's degree in communications. Alexa Cobbins is our third panelist, and she has over a decade of experience working with and for Black women and their families, um, specifically in San Francisco through her work with the Department of Public Health and San Francisco Human Services Agency. And Alexis will share tonight some of her own experiences related to preterm birth, which spurred her to serve 3 years on the Community Advisory Board for the California Preterm Birth Initiative, and which has transitioned her into her current role as Associate Director of the California Preterm Birth Initiative. Alexis has her Master's of Social Work degree from California State, East Bay, and she is experienced in transformative work around trauma-informed care, grief and loss therapy, as well as her work related to community violence, anti-poverty initiatives, and anti-racism work. Vu-Ann Foster, who's our fourth panelist, she's the founder of Life After Two Losses, which is near and dear to her heart professionally, academically, and personally. Vu-Ann received her Bachelor of Science in Public Health from William Patterson and is currently pursuing her Master of Public Health from Montclair State, and focusing on health administration and policy. I am rooting for her because she wants to get her doctorate in public health, and that is awesome, so that she can contribute much more to the field. She has been dedicated in advocating for improving maternal and child health outcomes after experiencing her own preventable second trimester losses. She serves on the Legislative Medical and Events Committee for Star Legacy Foundation, a stillbirth awareness organization. Vu-Ann is very active on social media, so please look her up, like and follow. Charles Johnson, last but not least, and his own experience of tragically losing his wife, um, uh, losing his wife, Kira, due to medical staff inaction, has caused him to be deeply committed to both Kira and his sons, and also making sure that this tragedy never happens to another family. He founded For Kira, For Moms, which is an advocacy organization that works to improve maternal health policies and regulations, to educate the public about the impact of maternal mortality in communities, and also a peer support for victims' families, friends, and to promote the idea that maternal mortality should be viewed and discussed as a human rights issue. So his very notable work in helping to get past critical legislation, where he was tenacious and relentless in this, and Congress in 2018 passed the Preventing Maternal Death Act. And this was a milestone legislation. So we have some amazing panelists with us, and I'll stop my jibber jabbering so that we can get on with the show. So please meet our panelists. Okay. So welcome everyone. So tonight, I really want us to have a sort of a discussion. This is friends gathering around a table and talking about critical issues that are happening in our nation and affecting um, Black birthing families in America today. And our first question is really around this matter of looking at the intersection of race and maternal mortality. As we know, recent research has shown us that Black women are 3 to 4 times more likely to die around in and around pregnancy and childbirth than their white counterparts. Can you share a little bit from your experiences about what is happening at this intersection of race and maternal health?
Thank you, Rebecca. And it is an honor to be here with all the panelists today. I think Black women are 3 to 4 times more likely to die from complication of pregnancy than their white counterpart because they are not receiving the care that they deserve, like the standard care that they deserve. And I also think that Black women are not being listened to. They hear our concerns, but they are not really listening to us. And also providers often filter Black women concern through the lenses of their own biases. And by doing so, they do not believe Black women and they do not act readily to address those concerns, which lead to negative outcomes. And I'll also add that it's very unfortunate because healthcare providers know that the essence of listening to their patients is to be able to provide them with the appropriate care. And we know that when patients receive the care that they deserve or they need, they have desirable outcome. And what impact Black women is impacting Black infants and their families. And for me, this bears the question to what value does the healthcare system really place on Black infants' life? Because Black infants' life matter too. And I want to add that while these issues may be emerging to some folks out there, these are issues that most Black women are very familiar with, and they either have gone through these themselves or know someone who have. And also, in addition, I would just add that Black women do not have any protective factors when it comes to maternal health. Not even education or income level is preventing Black women from dying from childbirth. And in fact, the birth outcome of a college educated, insured, and middle income Black woman is comparable to that of a non-college educated, uninsured, and poor white woman. So Black women are doing all in their power to have good outcome, but they are often discriminated in the healthcare system. And this is leading to the negative outcome that we are seeing in the gap between Black and white maternal health outcomes.
Thank you, Rachel.
So if I could piggyback off what you said about the not being listened to, I've definitely had a number of experiences in my pregnancy where I was not listened to. In my first pregnancy, I basically was letting them know that I was having like a lot of back pain and just something did not feel right. And they kept saying like, oh, you're fine. There's nothing wrong with you, you know, and just saying different racial things like, oh, we've seen women who have babies and they're on drugs and they're fine. So your pregnancy is normal, you're fine, there's nothing wrong with you. Even after my water broke in my first pregnancy, they basically kind of just told me, which I was told was not the truth, just like, oh, just terminate your pregnancy. This pregnancy is over. I was also told that when that happened, they should have given me a number of antibiotics so that that pregnancy did not go septic, which that was something they never did. I actually ended up in a different hospital that I wasn't supposed to be in, and they didn't have my records. So they kind of just saw me as like a young Black girl. Basically, I was stuck 20 different times with the needle because they were convinced that they needed an HIV test. They needed to make sure that I did not have HIV. And what I explained to them was, if you just call my doctors, I do not have HIV. they stuck me so many times, I literally was aspirating. Like I couldn't even breathe. And when the nurse finally yelled, like, stop, stop, stop. Like we're doing harm to this patient. Let me just put some warm packs on her. Let me, like, obviously things are going wrong and, you know, it's hard for us to get blood. Let's just stop. And then later on in that experience, another nurse whispered into my ear. She said, next time, sweetheart, during your pregnancy, you might want to use condoms so you don't get STDs. And I said, I don't have STDs. In fact, in my pregnancy, I wasn't allowed to have sex because of my condition, which is incompetent cervix. And she said, oh, I'm sorry. I thought that's why your pregnancy went septic, because, you know, you had STDs. So again, in my second pregnancy, the similar things was happening and I was trying to catch it because I felt like my water was breaking. So I showed up in labor and delivery while I was still trying to get a hold of my doctor. And I'm like, listen, I think what's happening last time is gonna happen. They looked at me for like 2 seconds and was like, there's nothing wrong with you. You are fine. I get to the parking lot and the rest of my water breaks. And as I try to get a tech to like get me back in, the nurse, white nurse, replies, well, if it would have happened in here or it happened out there, it doesn't really matter, does it? And unacceptable, like unacceptable in so many different ways. So if they just listen to us, like we know our bodies, if they just listen to us and stop making assumptions of what they think it is, I think that would just make things a lot better. They don't, like, just stop thinking they know it all. And that's just my take on that.
So let me just add this. First and foremost, it's just an honor to be here with all of you all. Thank you for all the when it's great to see you. I am also cheering for you and looking forward to all the wonderful things I constantly keep. Let me jump in and say this. In my work, I constantly talk to families. I constantly reach out. And in this work, it is like being stuck in Groundhog's Day. We hear the same thing over and over and over from our Black women, that they were not listened to and their concerns were not validated and they were not prioritized, period. And those failures have catastrophic and oftentimes fatal consequences, right? And let me make it plain. The reality of the situation is, let's keep it real. We're gonna have a transparent conversation. Is that all of us have biases, right? That's the reality of the situation. But if you are in service in public health, if you are a nurse, if you are a care provider, we cannot afford for you to have your biases unchecked, right? Because if you are a civilian, you can work out your biases or your isms in your own time, or you and God can work that out when you make it to the other side, right? But if you are in this work and people are trusting you with their lives, then you have two very clear choices. Either A, you recognize those biases, you take steps to get better, or B, you need to find something else to do because the stakes and the consequences are far too high.
Absolutely. Thank you. Thank you both, Luann and Charles. Your experiences are learning points for us, and what you've said about the role that healthcare professionals need to play, and what all of you have said so far, and the role that healthcare professionals need to play in actually listening and checking our biases and aspects of self at the door before we enter into a patient's room, so that we can be present and hear them, is well heard, and something that I hope that all of those professors of nursing and doctors and educators out there are doing that from the training level of the health professionals. We haven't heard from you yet, Alexis. Join the conversation.
Yeah, well, I want to add in thinking about like some hopes for the future. I'm starting to see that there's a shift from considering race a risk factor and recognizing that it's racism. And people are deepening their understanding of racism as anti-Blackness and realizing that when you focus on improving maternal health by focusing on those most burdened by racism, you can improve things for everyone. I'm also starting to see the voices of Black women, men, and families being centered as the experts, and lived experience being valued as needing to be at the table in these conversations around solutions. And we also have Black women researchers entering the field like Dr. Brittany Chambers and Dr. Karen Scott, who are leading the charge around structural racism and building the body of evidence about the impacts that it has on health. And I'm also seeing Black women take matters into their own hands and start birthing centers and fundraise to have home births. We're creating our own solutions to having healthy births outside of a system that has repeatedly harmed and killed us.
Thank you, Alexis.
I just wanted to add, everything that was said is so spot on, and just the fact that just recognizing that this is the history for Black women, right? Like, if we look at the history of America and how Black women was raped, right? And like how our rights, at one point we were properties, and how we're deemed still to today as discardable and don't have value. So when we are not receiving the kind of support that we need, when we're not receiving the kind of adequate services that we need, it's all because of that system that was built on the fact that we were property, that we weren't valued in the beginning, and we still don't value people in society. So how do we expect these systems that was built on racism and sexism and all these other isms to really value our lives and see us as human beings, as worthy of adequate health and support and dignity and respect? I think it's super important that we are now recognizing lived experiences as expertise. And I think it's super amazing that Black women and Black families and the collectives are coming together to really shine a light on what has been happening for decades and centuries, honestly. And I'm super honored to be here and be on the panel with everybody.
Thank you all. What I'm hearing from our conversation is how important it is to have this lens to what's happening historically in the Black experience, particularly what we're talking about today is in America. And thank you all for sharing to this point a bit more about your own experiences and putting some context and lens into what's happening around the lived experience of Black women, Black families, and being able to lend some voice to that. So for this next part, I want to get a little bit into asking you some questions and hoping that you can bring out a little bit more. Ruanne shared something really, really important. I think that it leads us to this next question. So our session title talks about the concept of obstetric violence. And for those who might not know, obstetric violence is defined as the intersection between institutional violence and violence against women during pregnancy, childbirth, and postpartum period. And it occurs both in the public and private medical practices. For too many women, their pregnancy has become a period associated with suffering, humiliations, ill health, and even death. So Ruanne's experience shed a little light on this, but there are these manifestations of obstetric violence that we see in our medical institutions, which include pain. So having pain and not getting any care for it, verbal humiliations, invasive practices, and even physical or psychological violence, forced interventions. So can you all briefly share your experiences or any advocacy work that you've done around related to obstetric violence?
So I can touch on that a bit. So in my second pregnancy, it was recommended that I get this procedure called the transvaginal cerclage, which I was not told that was only an 85% chance that it would get me to 24 weeks. It wasn't until my pregnancy was over that my OBGYN told me that he did not agree with MFN. He really wanted to give me that procedure early on, but he never not once had that conversation with me, because had he would have had that conversation with me, I never would have went with that option. So I feel like most people, which I'm not, every woman has the right to choose. Most women left his practice after they've had multiple losses. I've decided that that's not really going to get me any change if I just leave. But if I put the pressure on him to do the right thing for me, that would possibly make him do the right thing for other women. And one of the things I've learned with staying with his practice was he then went in and sat in on my surgery for me to get my abdominal cerclage so that he could learn how to perform that procedure on other women if they have my condition. So no longer would women be having multiple losses in his practice. So I could have, like other women, I could have picked up and just said, you know what, this doctor is not right for me. And I could have went on to somebody else, but I'm like, no, I'm going to force him to do the right thing. So I've learned from my experience that sometimes it's best to just work with the providers. And that's helped me. And I know that that's going to help other women, but that's just something that I've done.
So I would like to add that in December of last year, I got pregnant. I have a 2-month-old now, and we just moved to a new state. We moved to Virginia, and my husband and I, we spent a lot of time trying to find the best doctors in the area. And after reading hundreds of reviews, we decided to go with one of the providers here. I went to my first appointment with this provider, and he was super late. He was more than an hour late and spent less than 15 minutes with me. And he handed me a packet and he told me to go read it, that he has information that I need to know when I'm pregnant. And as a healthcare provider and a healthcare advocate, I knew that that interaction was not okay. He did not access my literacy level to see if I could read or understand what he was giving to me, but I just brushed those concerns off. And during that appointment too, he ordered some labs that were drawn. So I went to my second appointment with him. He was late again. He came in with a student. He did not introduce the student to me, and he started discussing my health history and everything with the student. And 10 minutes into his conversation with the student, I interrupted him and I asked him, who was this? And he apologized that, oh, I should have introduced the student to you before we started. And what I noticed during the whole encounter was that the provider did not call me either by my last name or my first name the entire time. And when he left the room, he ordered some duplicated labs that I already had drawn during my first appointment with him. So his nurse told him that these labs were already drawn, but he did not even care to pause and update the lab order. And I went to the lab, I showed my healthcare record, I pull it up by chart to the lab tech and I said, hey, I already had those lab drawn during my first appointment and you don't need to repeat it. And she said, well, the doctor did not delete or update the order, so I need to draw it all. And she did. So when I was leaving, I left a note on a piece of paper and I gave to the nurse to give to the doctor. And my note was stating that the minimum I expect from my healthcare providers is to call me by my name. If you cannot pronounce my last name, at least call me by my first name. So when I went home, a couple of days later, I received a note from him and he said that my lab results were fine. And then I went to my chart and I noticed that there was a sharp decline in my CBC lab. My red blood cell and my platelets really low, but this provider is telling me everything is fine. You know, I was really concerned, but at the same time, I wanted to trust him. So I said, you know what? Okay, maybe everything is fine. My third appointment with the provider, I waited for 2 hours before he came in. And when he came in, I told him that I'm taking time off my work schedule to be here. And him being constantly late over 1 hour, it's been very inconvenient to my work schedule. He was very irritated. And he told me that he did not feel comfortable working with me. And he told me that I needed to find another provider, that we are not compatible. And I said, are we not compatible because I'm asking, you know, for you to be here on time when needed? He said, well, that's what he said. And then he said that I also left a note to his nurse asking the nurse, the note said that I wanted to be called by my name. And he said that that is not his practice. The provider told me he does not call his patient by name. And I said, you don't call them by first name or last name? He said he does not call them by name. And he went on and told me that he has a lawyer and his lawyer advised him from working with people like me. And I said, people who advocate for themselves and speak up for themselves. He was just quiet. He did not respond. In that moment, he called his manager and told the manager that he does not want to work with me anymore. And the manager told him, do you want to, think about it overnight and before you make that decision? He's like, no, I don't feel comfortable working with her, and he literally dismissed me from his practice. And the next day I had a conversation with the manager, and I told the manager that I do have a healthcare background and I don't need to lay this on the table every time I see a provider. And I told him that this provider is a classical example of white male fragility, and also a classical example why so many Black women are dying in childbirth. And she apologized, and she said she will talk to the provider. Well, I found another provider, not the one that one of my colleagues recommended to me. During my first appointment with this doctor, she took time to listen to me. She spent more than an hour with me just to understand my story. And I told her that my son was born at 35 weeks, and she said that I have a chance of my daughter being born like way too early. And she referred me to high-risk OBGYNs to do a cervical exam and an ultrasound. And she was very concerned about the lab that the previous doctor transferred to him. And to her, she said that my red blood cells were very low and the platelet were low too, and she thinks I'm anemic. And she said she had to repeat those labs. And when those labs came in, my labs like further declined. And she called me right away. She said, and put me on high dose of iron. And because it was so abnormal for my hemoglobin and platelet to be so low that early in the pregnancy, she referred me to a hematologist. So I had a whole team that was taking care of me. I went to that appointment with the high-risk doctors, and then they found out that my cervix was completely effaced. The baby wanted to come out less than 20 weeks. And they told me that they had to perform an emergency circulation right away, which they performed. And luckily, I went through 37 weeks of pregnancy. And then at 36 weeks, I went there, everything was fine. 37 weeks, I went to my appointment, and the doctor came back and she told me that, the baby is not growing like the way we expect the baby to grow. So we need to take the baby out as soon as possible. My doctor and her team got together, scheduled a C-section, and the next day, I had a C-section and my baby was out. And I think from my experience, I think I was only able to be okay with the baby, first because of God, but also because I spoke up. I was a huge advocate for myself. It was not feeling right, and in the absence of having a provider who genuinely cared about me, I had to listen to my God. And that literally saved me in my, and during the pregnancy and my having a healthy child.
Thank you, Rachel. So we've talked a little bit about obstetric violence and had some really clear examples come out from both what Luann shared earlier and the examples that Rachel just gave in her description of what was happening in her clinical experience with the provider. So for us to have some more context around this and to understand what we're trying to move towards today, is I would like to ask this of all of our panelists, but if we could hear from Charles and from Alexis on this, what are the solutions or methods of disrupting the status quo of these violent and oppressive systems in maternal health? What are ways that we can become agents towards the solution?
I'm happy to go second. I'll defer.
Okay, I'd like to say, we need to turn the gaze from what Black women need to do and designing interventions for Black women and putting all of the onus on Black women advocates and providers to raise awareness and solve these problems. And we need to put our attention on what the institutions need to do and create interventions and strategies to help dismantle racism inside of these institutions. When I was being mistreated during my last delivery, I didn't need to know what resources were available to me or what programs I could be a part of. I needed my provider to not be racist. Everybody needs to contribute to changing things. So yes, we need to center Black women's voices and lived experiences, but that does not mean that everyone else stands back and does nothing. You don't just leave it to Black women to figure it out. We all need to be in action around dismantling racism while upholding lived experience as the ultimate voice in our action plans. Policy also needs to be instituted. In California, we passed SB 464, the California Dignity in Pregnancy and Childbirth Act, and it's designed to begin to address the harms caused by racism. This important measure will require hospitals that provide perinatal care and birth centers to implement an evidence-based implicit bias training program for all healthcare providers, as well as require the tracking and sharing of maternal death and severe morbidity. It requires evidence-based implicit bias training for perinatal inpatient providers in California and publication of maternal morbidity mortality data stratified by race and other determinants. It improves death certificate reporting to get more accurate maternal death counts for California, and it improves community education about ways to report experiences of healthcare associated discrimination.
So thank you. Let me jump in. So I really want to amplify how important that measure is, and the steps that California is taking have to be replicated and built upon on a national level. It's a must, right? It's an important first step. And let me just talk practically how, because Alexis shared a lot of very important information, but let's talk just for a second about collecting evidence and death certificates, right? So for instance, in Kira's case, right, when she passed away, for those of y'all who are familiar with what happened to Kira, I'll very briefly go over, she was allowed to bleed internally for 10 hours after it was supposed to be a routine scheduled C-section at Cedars-Sinai Hospital in Los Angeles, while we begged and pleaded for her life, right? And they did nothing. Those who are familiar understand that I'm not gonna say there's no greater, but this is a very clear-cut example of a preventable maternal death. But when we go to tracking the data, there wasn't even a place on Kira's death certificate to indicate that she was pregnant, right? And so as we're trying to track these deaths, it's so important that we are having more efficient and more effective ways to keep track of and then investigate these deaths. That's very important. I want to also go back a little bit too. And I think that what Alexa said was so important too, because it is not enough to put the onus on Black women to save the day. They've been saving the world at every junction for centuries, right? And the reality of the situation is what Rachel talked about, and having the courage to go in and stand up to that provider, that is not the nomenclature, right? We are taught to trust our providers, right? We're taught that they have paid all this money to go to school for all these years and they must just be right. And a lot of times people are just taking it and putting up with it. Beyond that, what happens to the young Black woman who is in East Armpit, Alabama, and there is no other option, right? There isn't a place for her to turn and select another provider, right? So we have to mandate institutional, structural policy change that does the work on behalf of African-American women, not only African-American, but all women, because the reality of the situation is if we can fix this for Black women, we will fix it for all women, right? And beyond that, we have to take further steps about another thing. I'm jumping all over the place, but I want to talk briefly about how important provider transparency is. We talk about the obstetrical violence, but the transparency, what Luann mentioned about her provider not being fully transparent about her options and the potential outcomes until it was far too late. That happens far too often. In our instance, we went in, we found a provider, we researched him, we trusted him. He recommended the cesarean in Kira's case, but then referred us out to somebody else who ended up being largely responsible for her death. And we didn't find out until the California Medical Board did their investigation that he no longer even performed cesareans, and he failed to disclose that to us, right? So we have to talk about provider transparency. We have to talk about informed consent being more than just a piece of paper, right? And what that means. And so as we are working on institutional structural change, us as advocates, we have to make sure that we are doing the work to make sure that we are educating and informing informed, empowered mothers to be. That's critically important, so that there has to be a meeting in the middle of providing and building a community of informed and empowered women and families that can advocate on their own behalf.
Thank you both, Alexis and Charles. I think that both of you are bringing up already elements of what I hope we can talk about in our next two questions. But first, I want to touch on something that Charles just said about what might Black women and Black birthing families need in order to navigate these systems. Charles spoke a little bit about the need to in your case, as well as in others' case, you researched the provider and all these things, but what else might Black birthing families need in navigating and also advocating for themselves in maternal health care? And how can they navigate the health system and maintain the autonomy over their bodies? And what might that look like? And that's for anyone on the panel to answer.
So I can answer that. I used to work at University Hospital, New Jersey. And one thing some people don't know, but some hospital has advocates. So basically, if you have an experience that is not a great experience, there's like a patient relations office, and you literally can call, you can have a family member walk in, and you can basically say, I need an advocate because I feel like no one's listening to me. And when I did this work, I literally would go around and rounds on every patient that we saw. And if there was an issue with the provider, I would bring it to their attention. And what I would do is document on every case, because after so many documentation of the same providers having the same issues, there would be repercussions to those actions. So I think people need to see if their hospitals have advocates and reach out to the advocates, because once someone reached out to me, most of the time that provider stopped. So that's just an option.
Thank you, Buren.
Yes, advocacy is a paid position in the hospitals. Somebody asked that in the chat box.
And I will also add that don't be afraid to have difficult conversation with your healthcare providers, and be very explicit about your needs and the outcomes that you desire. And, you know, for instance, when I was pregnant and, you know, I was working with the second doctor, I had a conversation with her and I told her that I appreciate how much she's been a great doctor and a great advocate. And when it comes to labor and delivery, I also want her to do all she can for me, because both me and my baby need to walk out of here alive. And that conversation kind of increased the trust level between us and improve our relationship and transparency. And also I'll just add quick that it's worth to request your chart to see what your doctor is putting in it. In case of the old doctor, I found out that he was putting things that were very inaccurate in my chart. So you have the right to know what the doctor is putting in your chart, and knowing that can lead you to decide if you need to speak up or just find another doctor who is being truthful with you.
Thank you both. Now, I want to turn it to looking at what we've talked about a little bit already, and this is what both Alexis and Charles focus some of their portion on, is looking at the clinical and public health professional side. I would really like to, for you all and whoever would like to chime in on this, how can public health and clinical professionals navigate this landscape of knowing that there's these structures of racism, but realizing that they want to be what we've termed as co-conspirators, those who would assume some risk in dismantling these structures, but how can they make that move in their own work in maternal health care?
Okay, well, I'd like to answer that, and starting with listening to Black women, listening to Black people, know that Black people are the experts of Black life, and there's no degree or certificate you can have that outweighs the expertise of lived experience. Educate yourself about racism and be an active participant in dismantling it. Read about and deepen your understanding of anti-Blackness. Take the word racist out of the good-bad binary and recognize it as a socialization. Be self-reflective and identify the ways that you have been complicit in allowing racism to kill Black women and children in the delivery rooms of hospitals. Realize that being anti-racist is a journey, not a destination. You must be on a lifelong path of education and self-reflection. Learn about all the ways that racism impacts Black people. Focus on the intentional exclusion from resources and opportunities and use your privileges to fill in those gaps. Donate to Black-led, Black-serving orgs and efforts. I'm gonna name a couple that I know of. Donate to Expecting Justice. Expecting Justice is a Black-led collective impact effort in San Francisco, working on innovative approaches to eliminate health inequities for birthing people. These programs include anti-racism trainings for medical and social services providers, doula support for Black and Pacific Islander parents, and other initiatives focused on supporting women and other pregnant people who are experiencing racial disparities. Donate to Sister Web in San Francisco. Sister Web connects pregnant individuals in San Francisco with culturally compatible birth companions who can help parents to receive the education, resources, and support they need to enter into their birth and parenting journeys with confidence, respect, and dignity. Sister Web strengthens and diversifies the birth provider workforce as well by training and mentoring birth companions and building relationships with traditional healthcare providers such as physicians, midwives, and hospitals. Donate to the Chicago Southside Birth Center. The South Side of Chicago is currently experiencing a maternal health desert. The South Side of Chicago is in desperate need of more laboring and birthing options. The creation of the Chicago Southside Birth Center would aim to stand in the gap of limited maternal health services and increase access to more birthing options. This effort is being led by Black midwives who are also mothers and know firsthand the importance of culturally based, patient-centered reproductive health care that focuses on improving birth inequities, reducing health disparities, and concordant health care. I can definitely drop these orgs into the chat for people as the panel's going on, but that's what I have to say. Put your resources into supporting Black-led efforts around this as well.
And I would like to add that we also need more Black providers to be taking care of Black women. And also when a Black woman come into your office as a provider, just keep in mind that that Black woman is experiencing chronic stress. And Black women experience chronic stress over their lifetime due to racism. And just keep in mind that the consequences of that chronic stress is leading to a phenomenon in Black women called the weathering effect or accelerated aging. And what this does is it weakens and it suppresses their immune system. It dysregulates their neuroendocrine function, and it also causes damage to almost every single system in their body. So when a Black woman comes to your office during pregnancy, just keep in mind everything that she's already going through in her life due to racism, and try your best not to be one more stressor that she has to encounter. And if you see something, definitely say something. You know, it takes a lot of courage to speak up, but those people that are in power, they definitely need to hold their providers accountable. Because if they are not holding them accountable, they will not be very conscious about the interaction between them and Black women. So holding providers accountable.
Can I just add something really quickly?
Go ahead, Ruan.
Which I started and I saw somebody mention it in the chat. I also, if I tell a doctor or provider that I need a service and they're not willing to provide that, I ask them to document it in my chart. And usually after I do that, I'm usually given what I'm asking for. So I think we need to start teaching, women and families that if a doctor is gonna basically tell you, oh, I'm not gonna provide you this, then it needs to be documented in our chart. So then in case something does happen, there's documentation that we asked for this service and it wasn't provided.
Yeah, absolutely, absolutely. I think that's an excellent point, Gwen. I want to just kind of bring back home what Rachel said and what happens when people choose to not go against the norm. when I began to talk to other nurses at Cedars-Sinai about the doctors and the people that were involved in Kira's death, everybody was aware of their track record. Everybody. The nurses knew, people who were there know the bad actors, know the people who rush C-sections, do unnecessary interventions. People know. The reality of the situation is, I get it, it might be difficult to have these conversations and hold people accountable, but trust me, your concern and your trepidation is nothing compared to what it's like to try and tell a son that his mother's never coming home, right? There's nothing compared to what it's like to try and explain to a son that will never know his mother just how amazing she is, right? So the reality of the situation is, you have to step up, you have to hold people accountable, right? Because there are families like mine and hundreds of thousands and millions more that are counting on you to do that, period. It's just that simple. Okay, let me say this. So they're usually ostracized if they speak out. Okay, look. Look. Let's talk about ostracized. Ostracized is a kid going to school and feeling ostracized because he doesn't have a mother. That's ostracism, right? So if you're not able to sit at the lunch table with the other nurses, right, or you feel that you're being picked on, like, the stakes are so much higher. And I don't mean to make light of it, because I know that this is difficult, and I know that sometimes there's retaliation in these instances. But the reality of the situation is, and then when you speak up, make sure, just like Luann insisted, make sure that your grievances and your concerns are documented, right? Because it's so critical, it's so important.
Thank you. Thank you. I feel that, especially being a nurse, and being an educator, and teaching in a nursing school, these topics that you all have introduced are something that that we all need to incorporate into our conversation and our dialogue with clinical professionals, public health professionals, so that it's no longer becomes a taboo that we talk about these things, that the uncomfortableness of racism that you might feel, or talking about the word race that you might feel, is not as great as when someone loses their life, a child loses their life, or someone loses quality of life because of your inaction. So our conversation continues, but we want to open it up. So I'd like to invite our audience to please put some questions. I see some already in the Q&A. So we won't be answering questions directly in this next segment for the next about 10 minutes or so. We will be getting some questions from the audience. So please make sure you put some questions in the Q&A for our panelists. And panelists, you can take a look at the questions. You should be able to see it on your screen if you press on Q&A. And I'm going to try and pick out at least one to start, and then you all can let me know if there's others that you see. Okay, one question. This question comes from Jordan Mosley. As people who have experienced what is wrong with obstetrics and the healthcare system, what advice do you have for future doctors, and what tools, not within the medical system? I think that let's focus on the latter part of this question, because what tools not within the medical system can they use to not continue the oppressive cycles?
I would say I'm in the medical field as well. So I would say take some cultural competency courses, because those are crucial, especially when you're going to be working with a wide range of people, or especially if you're going to be working in a community that is different from your own.
And I will add that just be comfortable. If you are a white person, be comfortable around people of color. Because if you are not comfortable around them in real life, when you have to provide care to them, you will definitely not be comfortable. And that is when the harms comes up.
I mean, also, as I've highlighted earlier, continuing on that journey to be anti-racist. There's books, there's articles, there's resources that you can read and continue to self-reflect and self-examine yourself. And know that that journey is not like, it's not going to be pretty and wrapped up in a bow. It's going to be messy, it's going to be mucky, but it is so important to saving the lives of Black women and Black children. So important so that children can grow up knowing who their mother is. So important so that people are around to see their children's lives excel. So there's so much at stake that the little bit that you can do to read up about racism is nothing. Like, it's nothing. It's something that you can commit to. It's easy to do. It was easy to commit to, and it's a journey that's worth going down, and it's a lifelong journey. So I'd like to highlight that. You continue to educate yourself. It's not a training you take once a year to check off a box and keep it moving. It's something that you have to continuously be in the practice of engaging with.
Thank you both. This question comes from Mary Ann Castle, and she asked a question about the perspective of doulas. And she's worked with 3 in New York, and she's asking the question, could you discuss the perspective of doulas and how that might be something to support community of women who are Black and birthing?
I mean, if nobody else wants to jump, I'll just mention, I think that doulas are super important. I think that they are, can make a huge difference in people's journey to motherhood. And I'm a big proponent of making sure that we have, more programs that are helping with access. We're making sure that we have integrated models of care, that doulas are accepted in hospitals and able to birth and not be, once again, ostracized, but that they're accepted by the team that's supporting the family, and they can work in conjunction. That's not necessarily, I'm certainly not a doula, but I do certainly recognize and appreciate everything that doulas do for families.
Okay. So panelists, if you see any questions in the chat that I might not see, please feel free to answer them. I'll scroll a little bit further down and pick another question. This one is from Uzameka Nafor. And the question is, do you think having more African-American health professionals addresses the maternal disparities in the African-American community? Will this make a difference in eliminating these disparities?
It's a start, but it's not the complete fix. I think that it's we must have more African-American representation. We have to have diversification in the workforce, but it's more about dismantling the systemic issues, right? Because it doesn't matter, a brown face can only do so much if they're in a culture or a system that is grounded fundamentally in racist practices or biases, right? And they don't have the tools to help support the families adequately. So it's important, but it is not, it's the same thing, like, is having more Black police officers going to, it's not going to be the fix. It's great, but it's not going to fix everything that's going on.
So I see a question in the chat that I wouldn't mind answering.
Go ahead, Rand.
Okay, so Tiffany said, I'm a future public health researcher. In your opinion, what needs to be better understood and brought to the light in the realm of maternal health outcomes? So I am too in the public health field as I'm completing my master's in public health. And I feel like one thing we all need to do in a sense is check our biases, because I recently just had an experience with a couple of classmates who we had a group project where we had to talk about breast cancer in Black women, and a lot of the factors that they were given were stereotypical. So I feel like we need to check our biases at the door. We need to talk more about systematic racism, and I think as a public health professional, that will help as far as getting into those conversations.
Thank you, Buan.
You're welcome.
I see another question here. It says, how can we protect Black women who are criminalized or incarcerated? They have very little autonomy. So many fixes, finding a new providers are not available to them.
I mean, I can jump in since that's my expertise. So women on the inside do not have the opportunities to choose a provider, right? Doesn't have the opportunity to choose where they go see a doctor at, doesn't have the opportunity to voice their concerns like somebody out in society or in public, because there's consequences associated with every time you do speak up. I was incarcerated at the age of 19 and I was pregnant at the time. And the level of violence against Black women inside is even more heightened than the level of violence against Black women on the outside. And because you're in a closed systems, which jails and prisons are closed systems, you're not able to have accountability, you're not able to have transparency. So then what happens is it's even more levels or mortality rates, it's even more levels of violence against women, and it's less chances for us to be able to speak out. So we, like at one point, in 2015, after I came home, I got involved in an anti-shackling campaign. And the reason why we did anti-shackling was just to be able to show the public a very specific way of how barbaric the system is. So if you are shackling a pregnant woman, it shows the level of risk that the woman and the unborn child is experiencing. So even more chances of the mom to be hurt and to have major complications, even more chances of the child becoming stillborn, having very high rates of dying, and more accidents within just being shackled and going through excruciating pain all day, every day. So we had this campaign, and what it showed us was that, one, we are a system where even when we have examples of Black women coming out and speaking out about how they was being shackled and handcuffed illegally, because there was already a 2009 law in New York State, even though there was a law that was in place that was supposed to be protecting the women from these illegal activities, it was still happening because there was no accountability. So it's what we did with the 2015 campaign is that we wrote in a bill, which became a law, was that every officer inside of the facility needed to be trained to not shackle, which sounds bizarre, but something as simple as, we have to train you to not shackle pregnant women. We have to train you to not sexually, physically harass pregnant women and women in general. Another thing we did was we had the ability that everybody that's coming inside of these facilities to be educated about the rights of what happens. Like, so if it is illegal to shackle pregnant women throughout pregnancy and 8 weeks postpartum, that every woman knows their rights. So even if it's not happening to you, you're able to reach out to somebody on the outside to share what is happening to somebody else that don't have family on the outside to advocate for their rights. I had a very specific example of how, while I was giving birth to my daughter, there was an officer and the doctor in between my legs arguing about, just, can I have some dignity? And why was it a need for that officer to be between my legs at the same time when the doctor was there trying to help me deliver my child? And, we need to understand that these healthcare professionals have more of a right and authority to speak up and to speak out. without consequences. And that for me, I wasn't able to be able to say like, no, I did not want this officer there, because I knew that once I got back to the facility, there was going to be repercussions on my end and consequences on my end. And I didn't want that, but I wanted the doctor to know, which I was trying to say with my eyes and not with my mouth, was that like, you can speak up for us. You can speak up for us. You have the right to tell him to move back. You have the authority and we don't have the authority. Instead of playing a, putting a burden once again on Black women to speak up and say what they need, sometimes they have to be the ones to do it, because it in those situations when you're incarcerated, you don't know what's the consequences. It's not just, oh, you go to solitary confinement. It could be physical harm. It could be so many different things. And it can be so catastrophic for that individual. So we can't take those kind of chances. And we need people to be in partnership and be willing to stand on the fact that, like, if you took an oath to protect that patient, if you took an oath, then you honor that oath no matter what that person looked like. And you don't, regardless if that person is incarcerated, regardless if that person is Black, whatever it is, you have to honor that oath to give them the best chance of having a successful experience, whether it's giving birth or just showing up to an appointment and, trying to get information about what is actually going on, and believe in us when we say we experiencing what we're experiencing. So.
Thank you, Miyoshi. The experience of, we have to, realizing that the experience of those who are most marginalized in our community actually just magnifies what's happening throughout our community. And I am so proud to say that there are a lot of organizations who are joining in this fight, especially to amplify the voices of Black birthing incarcerated women and the injustices that they've been facing. And thank you for contributing to that, Miyoshi. There are two questions in the chat directed towards OBGYNs. One is, what are the pathways to advocacy? And then the other is more on looking at the whole team dynamic. And I'll read this one in its full length. And it says, as Black women and as a Black woman and an OBGYN, what is something that I can do to ensure that my team is doing to improve the outcomes for Black families? So the question is around, how can you advocate? And then how can you ensure that your team is doing their part to solve the problem?
I can touch on advocacy if you would like.
Yes, please, go ahead, Vera.
Okay, so for me, I wasn't, I guess, originally given a seat at the table, so I made a seat at the table for myself. That's how I started life after 2 losses. So I feel like just share your story, one. Just keep speaking up about the issue no matter where you're at, and people will take notice. That's something that I've done. And a lot of people have taken notice from me just sharing my story and just not being silent about it. So, and if you want more, I guess, efforts, you can definitely reach out to me. I put my chat info in the chat box.
I'd also like to add that it's important, as you and your team are thinking of strategies around this and are focusing your attention on racism and how it impacts, that we think about racism and all the systems that are pushing this on Black people, all the intersections of it. We know that racism is a stressor. And so thinking about, there's some statistics coming out of the Black census that, like, Black women are mostly head of household. So, like, there's economic impacts on Black women. When we talk about mass incarceration, one, Black women are ignored in that conversation, right? Because there's a focus on Black men, but two, even with the focus on Black men, who is the economic burden on? Who's taking care of them while they're incarcerated? Their mothers, their sisters, their significant others, so thinking about all of the different ways that racism is impacting your client, your patient. I'm a social worker by training. Just like there's racist experiences happening in the medical field, they're also extra happening in the social services field, where people are probably going to be engaged a lot longer, right? So, like, how can you speak out to make sure that other providers are not replicating these same things that are happening in maternal health. So those are some of my suggestions.
And then just encourage them to listen. I think the best thing that, one of the best thing that they can do is to listen to the patient. And when we are talking about listening to Black mothers, like listen to them without adding anything to what they're telling you or subtracting anything from it. That's how you can get to know like what is happening and how you can take action to protect them. And they should also be comfortable to level down the patient provider dynamic. Like I'm the patient, you are the provider. I'm the provider, you are the patient, and you can tell me what to do. Trusting that these women know their body best and just believing the experiences is so crucial.
I think that in that final statement that Rachel made, she introduced something that I think has been a thread in what we've talked about tonight, is this matter of shared decision making, that as health professionals, we have power. We literally have the power over people's lives. And so our coming forward and speaking and seeing that eye gesture, as Miyoshi had said, of like, help me, is a call for us to respond and not kind of sweep things under the rug, and actually include our patients as the ones who know their bodies best. Thank you all for shedding light on that. We have 1 minute. Does anybody have something that they would like to say in this final minute that they just want to get off their chest? And for all those who've asked for contact and Twitter handles, we will make sure you get those in the chat box before you leave. But is there anything that you would like to share that's burning and you need to get off your chest, panelists, in this 1 minute?
I got something. So I have Muhammad Gandhi's quote on my door every day when I leave my home. So I see it and just manifest it. And that's basically be the change you want to see in the world. So basically, I see a world where women's pregnancy outcomes have nothing to do with the color of their skin. So just if we all do our part, we can make this better.
Thank you, Bruanne. We're all going to be taking actionable steps in the next segment when we get to our breakout groups. But before we go to our breakout groups, I want to say thank you to our panelists for joining us tonight, for getting this conversation started, and for giving us some very key examples of what's happening in the Black birthing experience, as well as what are some of the solutions and critical ways that we can become change agents and actually begin working towards dismantling these structures of racism. Thank you, panelists. Coming up next, we're going to have an opening to our breakout time given by Dr. Kamara Jones. Dr. Jones is a senior fellow at Morehouse School of Medicine and has done influential work in really naming and forming stories that we could tangibly get connected to around what is racism and how does racism manifest itself, and what are the critical steps that we can take to change and dismantle the systems. And so without further ado, I'm going to allow Dr. Jones, who is the author of the Achieving Health Equity Framework that we'll be using during our breakout time. Dr. Jones?
Yeah, thank you. This has been amazing so far, and I know it's just going to get more and more amazing. So first I have to say, Public Health Nursing Section, thank you for making this the 5th annual Racism Pre-Conference. You guys supported me, and I guess I supported you in 2016, which was the first. That was the year of my APHA presidency. And so I'm so happy to see the work really, really, really going on. In just a few minutes, there was so much wisdom dropped right there. I guess I want to just say 2 things. Well, so as APHA president, I launched this national campaign against racism with 3 tasks: to name racism, ask how is racism operating here, and then organize and strategize to act. Naming racism, the key messages we all need to have when we're naming racism are 4. That racism exists, that racism is a system, that racism saps the strength of the whole society, and that we can act to dismantle racism. So that's on the naming racism. On how is racism operating here? There were so many experiences shared just now and so many solutions. I just want to say, when we ask that question, how is racism operating here? It's a legitimate question, because racism is not like some cloud that we can't get a handle on. It happens through structures, policies, practices, norms, and values. That sounds like a mouthful of mush, except that those things are the elements of decision-making. So structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And the structures are the who, what, when, and where of decision-making. Policies, the written how, practices and norms, the unwritten how, values, the why. And as I was sitting there, so I took 5 pages of notes while you guys were talking, but I was just trying to say, because what we need to do, so we ask this question, how is racism operating here, so that we can identify levers for intervention, because the third of the 3 tasks of the National Campaign Against Racism is to organize and strategize to act. And when we organize and strategize to act, we don't all want to be acting on exactly the same one lever, because racism is a very fancy system and it'll just reconfigure itself and go around your work if you're just working on one thing. We need to organize and be working on different things. So structures as the who, what, when, and where of decision making. Well, the presence or absence of Black birthing centers, I said, would be an example of a structure. Also, all of the structures that enable people to keep on doing all the racist practice that they're doing. Policies, what if there were a policy to review every center and every provider for differential impacts on their patients by race, or differential practices and the like? Or the policy of anti-shackling was mentioned by Miosi at the last thing. Practices, so the practice of differential levels of care by assumed whatever, assumed social class, assumed whatever, or just your very Blackness, but also the practice of no accountability for violating the anti-shackling law. The norms of bad apple doctors being tolerated, being known and tolerated without accountability in the systems, or the norm of putting the burden on Black women to speak up for their own stuff. Yes, we need to speak up and our voices need to be heard, but the onus shouldn't be on us. And then values, the value or not of valuing Black voices in the first place. So what I'm saying is, as we think about moving to action, I have found that that question, looking at the who's at the table, who's not, what's on the agenda, what's not, all the other, who, what, when, where, that's structures. Looking at the written how of decision-making as policies, the unwritten how of decision-making as practices in the short term, and norms as the very long historical latent stuff, and then values as the why, can then help us identify a menu of 5, 10, 15 possible actions. And then we in a certain city or we in collectives can organize and strategize to act, people working out of their own passion, out of their own wheelhouse, and try to take the whole thing and take it down all at once. Because if we just piecemeal it, then the system would just reconfigure itself and keep on going. I hope that was helpful. Maybe that helpful, that was, I don't know. Can't hear you, Rebecca.
That was great. I think that you just recapped everything that we've talked about in the last hour, 10 minutes, and gave us a way to launch into our breakout times. So you all, we're going to have about a 2-minute intercession, and then everyone sign into your link that you received for your breakout group in about 4 minutes. Okay, so give us 4 minutes and then we'll have the breakouts ready. So you can leave now, and then at 7:25, go ahead and sign into your breakout group. And I'm so sorry, I forgot to introduce our breakout folks. So for those who have left, I'm sorry. I do want to introduce that Dr. Nastasia Davis will be leading our practice breakout group. And she has been engaged in really critical work during her her doing her work with the Perinatal Health Equity Foundation. And she is she has her DNP, and she is a nurse. And so she will be leading that breakout group and will be contextualizing for us what are factors in practice, that clinical practice that we need to consider. Also, we have Jack DiMatteo, who will be moderating the policy breakout session. And he works for the Office of Representative Lauren Underwood, and was very key in the development of the Momnibus policy in funding maternal health initiatives at the federal level. And then we have Dr. Dazon Dixon Diallo, who is the founder and president of Sister Love Incorporated, which has locations both here, well, I'm in Atlanta, as well as South Africa. And for over 30, her organization was the first Black women's HIV organization in the country. And she has done amazing work over the past 35 years on amplifying the voices of Black women and fighting for their reproductive health and justice rights. Okay, so with that, take your break and sign on at 7:25 to your breakout group.